Okay, our next speaker is going to be Dr. Pascale Carayon. Dr. Carayon is Professor Emerita at the Department of Industrial and Systems Engineering at the University of Wisconsin-Madison. She is the founding director of the Wisconsin Institute for Healthcare Systems Engineering as well.
It's not just about technology, it's about what we call socio-technical systems. And I'm going to build on what Beth was talking about, that idea of the patient journey and the cancer care continuum. But before I get started, I wanted to tell you about my perspective. I'm anchored in the discipline of human factors and ergonomics, and very much that systems approach. And I use the term system in terms of the socio-technical system, not just the technology. I'm an engineer, so I'm very interested in designing technologies that help people do their job. And so that's what we call human-centered design. And you've heard already that term in the presentation of Shiloh Anders. And all of that with the objective of improving patient safety as well as other outcomes such as well-being of both patients and clinicians, and of course, building technologies that help all of them do their job performance. I organized my presentation around the SIPS 3.0 model of the patient journey. So in oncology care, patients encounter multiple work systems that are represented by these concentric circles. So they may receive, for instance, a diagnosis of cancer during a visit with an oncologist. So those would be the members of the team. All of that happens in a certain physical environment and organizational environment. And then they would use different technologies such as the EHR. For cancer patients, again, that idea of the continuum, the care continuum of the patient journey is really important. Therefore, anything that happens in between those concentric circles, the interfaces, is critical. This is where care coordination is sometimes suboptimal. And how do we design not only the systems, but also the connections, the interfaces between the systems is a big question, so that we can improve not only patient safety, but other outcomes for patients, care partners, clinicians, as well as healthcare organizations. The model also includes feedback loop for adaptation, learning, and improvement. So let's look at one piece of that model, tools and technologies. We all have experienced good and bad technology. So let me just go through a couple of examples. The first example is one of the design of a medication drawer in a code cart. This is A is the initial design and D is the redesign medication drawer, where you can see the drawer is much better organized. You can actually read the labels on the bottles. There is a flow and organization of the medications that matches what people do. And the study by Ralsek and Holbeck actually shows that the redesigned medication drawers was more efficient, effective, and safer. Another example, this one is about an EHR interface for ICU physicians. The initial version shows an EHR interface with information that is scattered. There is very little, if at all, use of graphics, very little connection between the different pieces of information. And through a human-centered design process, the team actually designed that interface that you see on the bottom right that integrates information, that uses graphics, and that better support decision-making activities of ICU physicians. So there is actually a science, a structured process to going from A to B and from EHR interface top to bottom, where we look at what is it that people are doing. We try to specify requirements. We produce different solutions and then go through an iterative feedback process. So those methods are actually some of them are anchored in my discipline of human factors and ergonomics. So we have a bunch of what we call design principles or usability heuristics. We also have methods, what we call usability evaluation, for figuring out whether a technology is usable. What's really important that I wanted to highlight here is some of the key principles. In doing that, in using that structured approach, and Shiloh talked about that earlier, it's really important to understand what people actually do, not what we think they do, but what they do. I heard in an earlier sessions someone talking about how there were people shadowing clinicians. So this is the kind of things that we would do. And also, I wanted to highlight the importance of designing with and having key stakeholders and users participate in the design process. So it's not just about the technology, it's also how the technology fits with all of the other elements of the system. And we know that when the EHR is not well integrated in the workflow, that both clinicians and patients experience burnout and stress. There are a number of studies that highlight the high level of burnout and stress among oncology clinicians, such as physicians and physician assistants. And part of that stress and burnout is actually related to the EHR technology that contributes to high workload, poorly designed interfaces, a technology that does not help me do my job. That's what we hear. This EHR-related stress actually extends to that really important relationship between clinicians and cancer patients. So for instance, how the examination room is set up. And again, I heard about that, the importance of that physical environment and how does the technology fit or does not fit in that physical environment, how the screen is shared, for instance. So in order to look at workflow integration, of course, we need to understand who we are designing for, who are the people at the center of the system. And then we can go through a series of questions such as those on the screen. How can we support the task performed by clinicians and patients, the temporal flow, the physical environment, organization, and other technologies. And my last segment is going to talk about really that patient journey and understanding that care continuum. So it's not just one system, it's multiple systems. And for cancer patients, the patient journey is really one where there are multiple teams, specialists and primary care and so on. And they are what we call fluid teams because they change. The members of the team change and they are distributed over time, over space and in different organizations. And care coordination, and Beth earlier talked about the importance of care coordination, is really important. And how do we design technologies that help at those interfaces to support care coordination? Valentina Lischner and Melissa Bessari from the UK and Australia have really called our attention to looking at how do we design visualization displays that capture that complex care treatment as a whole over different time horizon. In the domain of survivorship care planning, and planning is a verb, Amy Tevarverk and her colleagues have highlighted the connection between different systems. So on the left side, you see the system around the survivor, the system of the oncologist, and the system of the primary care doctor. And when the patient moves to that survivorship stage, we can ask ourselves the questions of how do we design technologies that facilitates all of these great outcomes of access to common discrete information, increased shared work, and removing duplication. And Amy Tevarverk and her colleagues suggest that we need to go through that systematic analysis of who they are, what do they do, what tools do they use, in what type of physical and organizational environment. And that questioning then can allow us to come up with innovation in EHR. So in conclusion, I'd like to highlight three big recommendations. One is that there is a lot of knowledge that we can use to better design technologies. Number two, participation is critical. We need to design technologies for the users, but also with them and understanding what they do. And the last one is that design is tough. I'm an engineer, I've designed technologies. I know it's hard to do it. And so how can we build feedback loops and learn in a continuous design process? Thank you very much. And I look forward to continuing the conversation later on.
Okay, thank you very much.